A 1-year-old girl is brought to the emergency department because of 3-day history of low-grade fever, diarrhea, low-grade fever and watery diarrhea. She has had 8 to 10 watery stool daily that contain mucus but no blood. She has had fewer wet diapers as usual. She has not had vomiting and symptoms of the upper respiratory tract infection. But her father reports that she became very fuzzy. Earlier today, she had been drinking juice and children's electrolyte supplement, but not eating much food. Her older brother had mild upper respiratory tract infection and diarrhea last week. On arrival, she appears lethargic. She is at 25% length and weight. Temperature is 99, pulse 160, respiration 30, blood pressure 70 by 40. The mucous membrane are dry. The lungs are clear to auscultation. Cardiac examination shows a grade 1 by 6, systolic ejection murmur with no rub, and the abdomen is soft and there is no hepatosplenomegaly. The extremities are cool capillary refill capillary refill time is 3 to 4 seconds. The remainder of the examination shows no abnormality. Potassium 134, sodium 134, bit low, potassium 3.2, low, bit low, chloride normal, bicarbonate is very low, blood urea nitrogen maybe slightly high, glucose normal, creatinine 0.5, urine pH is 5, specific gravity 1.025, urine glucose protein is negative, ketone 3 plus. Which of the following is most likely diagnosis? Cramps. Ready?
Mm-hmm. Okay. It's this one. Huh? This one. Oh, lactic acidosis. This infant presents with tachycardia, hypotension, delayed capillary refill, acute onset diarrhea, consistent with a diagnosis of gastroenteritis with associated volume depletion. Children with gastroenteritis are at increased risk for volume depletion in comparison to adults. Clinical signs of volume depletion include tachycardia, tachypnea, hypotension, dry mucous membrane, poor skin turgor, prolonged capillary refill. Children may present with irritability or lethargy. Lab studies show perturbations on sodium, potassium concentration, volume depletion secondary to diarrhea. Is usually accompanied by significant stool loss of bicarb, which in combination with hypoperfusion of end organs with lactic acidosis may result in metabolic acidosis. Urinalysis shows aciduria, and an increased urinary specific gravity. Treatment includes repletion of fluid and electrolyte. It is not B. Diabetic ketoacidosis may present with volume depletion and metabolic acidosis. However, in infants, this is most commonly caused by type 1 diabetes, which presents with polyuria and glycosuria. This child's history of acute onset diarrhea and a sick contact are more suggestive of gastroenteritis. Poor feeding in acutely ill child may lead to starvation, ketoacidosis with mild ketonuria. Okay, next.
A 3-year-old boy A 3-year-old boy is brought to the emergency department because of 2-day history of watery diarrhea. 2-day history of watery diarrhea and vomiting. During this period, he has not had an appetite for food but has been drinking sugar-free soda. There has not been any change in the urine output on arrival. He is alert and interactive. His temperature is 99, pulse is 120, respiration 24 per minute, blood pressure 90 by 60. Blood pressure 90 by 60. Soft Examination shows soft, non-tender abdomen, no organomegaly. Soft, non-tender abdomen, no organomegaly. Bowel sounds are normal. Serum studies show sodium 140, potassium 4.5, fluoride 110, bicarbonate 15, and glucose 45 low. Bicarbonate low. Okay. Which of the following is the most likely cause of these findings?
My God, this one. Ready?
Yes.
Okay, so it is inadequate caloric intake, prolonged vomiting with inability to maintain adequate oral intake. Adequate oral intake and diarrhea can lead to clinically significant levels of dehydration and starvation ketosis. In this case, the child has adequate fluid intake and does not demonstrate signs of dehydration, but has inadequate caloric intake. Starvation ketosis occurs when glycogen stores in the liver have been exhausted, typically after 1 day of fasting. Following this, blood glucose is maintained primarily through the breakdown of muscle and fat um, to provide substrates for hepatic gluconeogenesis. After approximately 3 days of fasting, adipose cells in the stored fatty acids become the primary source of energy through the production of ketone bodies. These patient labs values include profound hypoglycemia, decreased bicarb, and increased anion gap as suggestive of starvation ketoacidosis in acute illness, prolonged fasting from persistent vomiting, diarrhea, and inadequate caloric intake. Starvation ketoacidosis is a high anion gap metabolic acidosis. If serum or urine ketones are measured, they will be increased. Production of ketone bodies will continue to provide the brain with energy source during prolonged fasting. It's not fatty acid oxidation defect will prevent formation of ketones. Instead, this patient is successfully producing ketone in response to starvation state caused by acute illness. His alert and interactive state supports that he's generating enough fuel for his brain to form in the form of ketones and thus must have functional fatty acid oxidation. It is not fructose 1 phosphate aldolase deficiency causes hereditary um, fructose intolerance. This typically presents with fructose containing foods such as fruit juice is introduced into the diet. Affected children develop hypoglycemia and vomiting after fructose ingestion. This child illness is acute and he has not been ingesting fructose. Okay.
A 10-year-old man, a 10-year-old male newborn is brought to the emergency department because of poor feeding and drowsiness for the past day. Poor feeding and drowsiness for the past day. He also has had 2 episodes of He also has had two episodes of vomiting today. He was born at term following uncomplicated pregnancy. He was born at term following an uncomplicated pregnancy and delivery, weight 3.6 kg. On arrival, he is lethargic. His shade darker than his parents' skin. His skin color is a shade darker than his parents' skin color. His temperature is 36.1, pulse 180, respiration 70. Blood pressure is 58 by 30. Anterior frontal alley is shrunken. The scalp has sparse, fine blonde hair. The nipples and the scrotum are darkly pigmented. The pupils are equal round and reactive to light and accommodation. There is no scleral icterus. The lungs are clear to auscultation. Cardiac examination shows regular rhythm, no murmurs 1 and S2. And the abdomen is soft and no masses organomically. Genital development Tanner stage 1. The penis is 4 centimeter long. Testes are descended. Serum studies most likely show which of the following.
Ready?
Yes.
Hmm. So it's BID, decrease sodium, increase potassium, decrease glucose. Congenital adrenal hyperplasia is a defect in adrenal steroid biosynthesis, particularly of cortisol, with variable effects on mineralocorticoid and androgens. Because of decreased production of hormones, the adrenal glands is stimulated by the pituitary in an attempt to increase hormone production, leading to adrenal hyperplasia, the namesake of this condition. The most common form of CAH and the cause of this patient manifestation is 21 hydroxylate deficiency. 21 hydroxylate deficiency presents with cell wasting in a newborn or precocious puberty in a child, as well as virilization of infant with an XS karyotype caused by increased concentration of androgen. Because of the enzyme deficiency, concentration of 17-hydroxyprogesterone, androstenedione, and testosterone are increased, while aldosterone and cortisol are decreased, leading to hypotension, hyperkalemia, hypoglycemia. Um, Diffuse hyperpigmentation of the skin as seen in this newborn is characteristic. Melanin production is regulated in part by melanocyte stimulating hormone MSH. MSH is a byproduct of propionmelanocortin POMC, which also produces ACTH. Okay. In adrenal insufficiency, stimulation of ACTH production by POMC simultaneously produces MSH, um, leading to diffuse hyperpigmentation in affected patients. Treatment with CAH consists of exogenous steroid and mineralocorticoid supplementation. Okay, next.
Next.
Mhm.
How they pick up this is congenital adrenal hyperplasia, like skin
Okay.
color.
Yeah, the skin color, the blood pressure.
Blood pressure
mm,
is very low. Low blood
mm,
pressure is congenital adrenal hyperplasia. They do not talk about any gonad like precocious puberty because in
I
congenital, yes.
I guess that's why they gave you the penis, but that's if you know the size of. I think they're trying to say that the penis here is long, the 4 centimeters. But I don't know the normal size of the penis for the babies, so I didn't. But I think if you Google, it's probably like 4 centimeters is probably long. I just didn't. I just don't know. So my key here was the dark um, pigmented thing, and then the signs of dehydration, like the sunken fontanelle and the blood pressure and all that, that means that that so that there is low hypotension, dehydration. So that's probably sodium that's not doing his work. Yeah.
Okay. Next,
Hmm.
a 2.5-year-old boy is brought to the physician by his mother because she is concerned about his language development. He uses fewer words his old than his two older siblings all at the same age did at the same age. He was born at term following an uncomplicated pregnancy and delivery. She has no history of serious illness. She has no history of serious illness and takes Modi. He has oh, his, he fits himself and plays well with his siblings and does well in the daycare. Motor development is appropriate for age. He knows 100 words but does not use them in phrases. Examination shows no abnormality. Which of the following is the most appropriate next step in evaluating child's language?
Okay. Ready?
Yes.
Is audiometry. Children with developmental delay should undergo audiometry to evaluate for hearing loss. Failure to detect hearing loss can cause preventable delays in child language, social, and educational development. Hearing loss in children may occur because of either conductive or sensorineural etiologies. A careful history and a general physical exam should be performed to evaluate for possible syndromic features. Um, Weber and Rhine tests can distinguish conductive and sensorineural hearing loss. The American Academy of Pediatrics recommends routine audiometry screening for all school-age children. It is not E. No further evaluation is indicated that this time is incorrect. Failure to detect hearing loss can cause preventable delays in child's language, social, and educational development. Mm,
Okay.
okay.
A previously healthy 17-year-old girl is brought to the physician 4 days after sexual partner was diagnosed with gonorrhea. Examination shows no abnormality. Testing for Neisseria, gonorrhea, and chlamydia are ordered. Which of the following is the most appropriate next step in the management?
Hmm, that's a good question. Do we give? I know we treat the partner, but do you treat them empirically, or
Okay.
if they have symptoms? Okay. Oh, intramuscular self-reaction in oral doxycycline. Neisseria is a gram-negative Staphylococcus, cause vaginitis, cervicitis, PID. Vaginitis typically presents with mucopurulent discharge, and pruritus cervicitis presents with similar discharge, but also with red friable cervix and cervical motion tenderness. When infection spreads to the fallopian tubes and ovaries, PID with purulent cervical discharge, uterine and adnexal tenderness, and systemic symptoms such as fever can result. If left untreated, PID can become complicated by tubovarian access and intra-abdominal abscess, presenting with focal tenderness and fluctuant mass. It can cause consequent infertility. Gonorrhea can present with dissemination, tenosynovitis, dermatitis, polyarthralgia, or reactive arthritis. Risk factors for development of gonorrhea include multiple sexual partners, new sexual partner, receptive anal intercourse, Young age substance abuse and inconsistent condom usage. Co-infection with chlamydia is common, therefore treatment typically consists of ceftriaxone and doxycycline, with the later um, with the latter covering possible chlamydial infection, while confirmatory tests are pending. In a high-risk exposure to gonorrhea, empiric treatment to cover both gonorrhea and chlamydia is appropriate. It's not intramuscular ceftriaxone therapy only will treat gonorrhea. However, risk for co-infection with chlamydia is high, and this antibiotic regimen will not cover a chlamydia infection. It's not where am I? No treatment indicated because this patient is asymptomatic is inappropriate. As failure to diagnose and treat this patient could lead to multiple complications, such as PID and all that. She has had high risk exposure to gonorrhea, and empiric treatment is more appropriate. Okay, so you treat empirically for both. Okay, next.
Next, a previously healthy 9-year-old boy is uh, brought to the physician because of moderate groin pain. Since she participated in a hockey game 24 hours ago, he recalls he recalls no trauma or injury to this area. He reports to a decreased appetite today. He has had no fever. He appears well. Vital signs are within normal limit. Examination shows edema of the left aspect of the scrotum. There is marked tenderness. There is marked tenderness to palpation of the superior aspect. There is marked tenderness to the palpation of the superior aspect of the left testicle. The patient does not improve with elevation. The pain does not improve with elevation of the testicle. A 3 centimeter bluish discoloration overlay the point of the maximum tenderness. There is no erythema. Cremasteric reflex is uh, intact. Genital and pubic hair development are Tanner stage 2. Which of the following is most likely diagnosis?
Hmm, ready?
Yes.
Mm. So distortion of the appendix testis. Testicular torsion occurs when testicle rotates about himself within the scrotal sac, resulting in vascular congestion and potential cessation of venous and arterial flow to the testis. Patients typically present with acute severe testicular pain, with diffuse tenderness and swelling and an absent crematory reflex. In contrast, patients with torsion of the appendix testis present with growing pain and non-tender testicle, a tender palpable localized mass adjacent to one pole of the testicle, and an intact cremasteric reflex. The appendix testis is a vestigial structure, typically on the anterior and superior aspect of the testis. It has a pedunculated shape that may predispose it to torsion. When tossed, the appendix testis may appear as a small blue or black mass in the scrotum. The diagnosis may be made clinically or with ultrasound in cases where testicular torsion cannot be excluded. While patients with testicular torsion require surgical torsion and orchiopexy to prevent infertility, management of torsion of the appendix testis is generally supportive. Um, with analgesic and scrotal support. It's not epididymitis is a common cause of painful scrotal swelling and refers to acute infection and inflammation of the epididymis. In younger males, this is commonly secondary to STI, such as chlamydia and Neisseria. Patients with epididymitis may have moderate pain relief with elevation of the testes, and it's not orchitis, is inflammation of the testes that result from an infection, and sometimes from mumps. Clinical manifestation include fever, myalgia, fatigue, especially when it occurs after puberty. It is a risk factor for infertility. Mm, can I Google the appendix? What does it look like? Sorry.
Which one?
The appendix testis. Testis. Is it like something that's on top of the? Okay, so it's this little thing. Okay, okay, got it. Okay, next.
Yes. Can we take 5 minute break?
Yes, we can.
Okay, I'm coming.
Mhm.
Yes. Okay. Question 7. A 1-year-old boy is brought to the physician for follow-up examination. He completed he completed 1 week course of IV ceftriaxone followed by 5-day course of amoxicillin for pneumococcal pneumonia 2 weeks ago and has been asymptomatic since then. He has had 6 episodes of acute otitis media for the last 6 months. Immunizations are up to date. He is at 50 percentile for length and weight. Tympanic membranes are dull and clear effusions. The remainder of the examination shows no abnormality. Hemoglobin 12, leukocyte count 8,500, segmented neutrophil 40%, lymphocyte 50%, monocyte 10%, platelet count is 42,000, IgA gain maybe low. Everything is low, isn't it?
Yeah.
Okay. Which of the following is the initial treatment for underlying condition? Ready?
Yep. Ready.
Okay.
So it is monthly infusions of immunoglobulin. Only infusions of immunoglobulin should be given to this patient with likely diagnosis of X-linked agammaglobulinemia. X-linked agammaglobulinemia is defined by defects in the Bruton tyrosine kinase gene, which is necessary for all stages of B lymphocyte development and proliferation. Deficiency of this enzyme, hmm, deficiency of this enzyme results in failed B lymphocytes development, as B lymphocytes are responsible for secreting immunoglobulin. Once they differentiate into plasma cells, a defect in B lymphocyte maturation leads to a death of plasma cells and severely decrease immunoglobulin concentration of every class, including IgM, IgG, IgE, IgA. Patients with present with recurrent infections caused by impaired humoral immunity and treatment is with IV immunoglobulin concentrates. It is not amoxicillin prophylaxis given to patients with congenital heart disease or those with history of endocarditis who are undergoing um, certain procedures. While amoxicillin will likely treat his current episode of otitis media, it will not correct the underlying problem. Okay, next.
Okay. An a 2-year-old boy is brought to the emergency department 30 minutes after 30 minutes after he was found in grandmother's bedroom surrounded by multiple open medication bottles. His grandmother states that her medication include imipramine, phenobarbital, iron supplement, aspirin, codeine. On arrival, the patient is somnolent, temperature is normal, bit low, 96, hypothermia, pulse 70 per minute, respiration 10 per minute, blood pressure is low, pupil is 2 centimeter and non-reactive to light. He is unresponsive to painful stimuli. Ingestion of which of the following is most likely cause of this patient's condition?
Ready?
Okay,
So is oxycodone. This is intoxicated with oxycodone, an opioid medication. Opioids are central CNS depressants used as analgesic and recreational drug. Opioids act through the CNS and peripheral nervous system and lead to euphoria caused by interaction with dopamine, alter mental status, sedation, bradycardia. 70 is bradycardia in like the 2-year-old, I guess. Hypotension, depressed, respiratory drive, and constricted purpose. Specifically, the mu2 opioid receptors located in the brainstem respiratory centers are on the peripheral chemoembaroreceptor control respiratory depression, which may be severe. Meiosis is a distinctive finding that is less common in intoxication with other CNS depressants. It is caused by direct opioid receptor activity. Okay, so 2 is meiosis now. I thought 2 to 4 was normal, but I guess 3 to 4 is, yeah. It is caused by direct opioid receptor activity in the brain areas responsible for pupillary control. Opioids also act on receptors within the enteric nervous system, reducing gut motility and causing constipation. The treatment of opioid toxicity, supportive care, respiratory support, and naloxone, short-acting opioid receptor antagonist. It is not imipramine. Imipramine overdose typically leads to cardiovascular toxicity like QT or QRS prolongation, CNS toxicity, acceleration, coma, seizure, and anticholinergic toxicity like pupillary dilation, dry mouth, tachycardia, urinary retention, um, pupillary vasoconstriction of bradycardia would be cool. It's not phenobarbital, it's a barbiturate CNS depression that has similar effect and toxicity to alcohol and benzos. The risk for dangerous respiratory depression is higher in barbiturates than benzos or alcohol. Pupils are typically normal in size. Okay, nice.
a 6-year-old girl is sorry.
It didn't say anything.
Okay, a 6-year-old girl is brought to the physician. 6-year-old girl is brought to the physician by her father because of 36-hour history of fever and 1 day history of pain and swelling of her joints. The pain and swelling begins at the right knee, then it increased, involved the both knees, now migrated on the left ankle and left elbow. He, he is currently unable to walk because of pain. 2 weeks ago, she had a sore throat that resolved after 2 days without treatment. She has no known drug allergies. She appears uncomfortable when she moves. She is at 50% height and weight. Temperature is 102 grade 2 by 6 fan systolic murmur that is heard best at the apex and accentuated when makes a fist. This there is mild swelling of the left elbow and both knees. The left elbow and both knees are warm. His ESR is 110, ASO titer is 800 Todd unit. Salicylate therapy is begun results in marked improvement of the symptoms. Which of the following is the most appropriate pharmacotherapy to prevent the recurrence of this patient's disorder?
Prevent
Ready?
recurrence. One moment. Prevent recurrence. Prevent recurrence. Oh no. Okay, ready.
Okay.
Is penicillin. This girl presents with rheumatic fever characterized by arthritis, matral rigors, following an episode of strep pharyngitis. Rheumatic fever is a sequela of untreated strep, um, group A strep infection, commonly pharyngitis, in which there is a type 2 hypersensitivity reaction to self antigens having a similar structure to and thus molecular mimicking strep M protein. Diagnosis is made by the Jones criteria, which describe many of the core clinical features of rheumatic fever. The major criteria include polyarthritis, carditis, subcutaneous nodal erythema marginatus, Sydenham chorea. The minor criteria fever, leukocytosis, arthralgia, PR interval prolongation. Patients often have increased antistreptolysin O titer. Biopsy of affected cardiac tissue discloses granulomatous. Reaction with presence of Ascotch body. Complications of rheumatic fever include mitral valve inflammation leading to long-term sequelae of chronic mitral valve regurgitation, prolapse, or stenosis. Treatment of the initial strep infection is effective for reducing the risk of developing rheumatic fever. But once rheumatic fever has developed, treatment includes salicylate and prolonged course of monthly penicillin treatment to reduce the risk of recurrence and further valvular damage. Okay. So non-pharmacology is incorrect. Failure to treat with penicillin increases the risk for recurrence of rheumatic fever with associated um, mitral valve damage. Okay. Next.
A 3.9 kg male newborn, a 3.9 kg male newborn, at term 30-year-old, primary abdomen, Apgar score are 8 and 9 at 1 and 5 minutes respectively. The mother's hepatitis B status is unknown, and the newborn received is unknown because she received no prenatal care. Maternal hepatitis surface antigen HBs AGU assays ordered. Examination of the newborn shows no abnormality. In addition to hepatitis B vaccine now, which of the following is the most appropriate regimen for the newborn?
Ready?
Yes,
Okay. So is Hep B IG only if maternal Hep B antigen is positive and Hep B vaccine are 2 and 6 months of age. The recommendation schedule for Hep B immunization and immunoprophylaxis in newborn is dependent on the maternal Hep B surface antigen status. Hep B surface antigen assay is important component of prenatal care and is typically checked at the first prenatal visit. Hep B surface antigen is positive. If Hep B surface antigen is positive or if there are signs of active maternal Hep B infection, the newborn should receive the first dose of Hep B vaccine intramuscularly and Hep B immune globulin as early as possible, with additional doses of Hep B vaccine at 2 to 6 months of age. If Hep B surface antigen, if in a Hep B surface antigen negative mom, only Hep B vaccine is needed, and doses are given at birth, 2 months and 6 months. As in this case, if the mom Hep B surface antigen status is unknown, but there is no evidence of active infection, the newborn should receive Hep B vaccine within 12 hours, and Hep B immune globulin can be delayed until maternal serologies have returned. If the serologies return positive for surface antigen, the infant should receive the immunoglobulin within a week. If serology returns negative for surface antigen, the newborn does not require immunoglobulin. In either case, the newborn will still require the second and third dose of Hep B at 2 and 6 months, respectively. Next.
Next. A 3-year-old girl is brought to the emergency department because of 5-day history of increased thirst and urination and a 2-day history of decreased activity. Although she had been previously although she had been previously toilet trained and dry at night, she has had several episodes of nocturnal wetting over the past week. She has not had fever, vomiting, diarrhea. 2 weeks ago, she fell off tricycle, but no injuries were apparent. Her temperature is 37.5 degrees Celsius, pulse is 160 per minute, respiration 24 per minute, blood pressure 80 by 60. Examination shows sunken eye, dry mucous membrane. The remainder of the examination shows no abnormality. Sodium is very high. Chloride is high, 125, 159. Potassium normal. Bicarbonate is low. Bicarbonate is low. Blood urea nitrogen is high, 43. Glucose slightly high, normal. Creatinine 1. Urine pH is 6. Specific gravity is 1.001. Blood glucose protein is negative. Osmolarity is 125. Which of the following is most likely diagnosis?
What is the normal osmolality again for the urine? You remember?
Is it 300 to 600? Isn't it?
The normal 300 to 600. Okay. Psychogenic polydipsia.
But this
Mm,
is baby.
Psychogenic polydipsia. And that will be low. Is ADH? Is ADH? Mm, no. Insipidus, blah, blah, blah. Mm, oh, very.
Yes.
Okay, so it is diabetes insipidus. Central diabetes insipidus may result from head trauma and is characterized by inadequate secretion of ADH, also known as vasopressin, from the posterior pituitary. ADH binds to V2 receptors of the late distal convoluted tubule and the collecting tubule, which results in the insertion of aquaporin channels in the luminous surface. This results in increased free water absorption and maintains star regulation of the serum osmolality. Inadequate production of ADH by the posterior pituitary may occur in various pathologies such as pituitary tumors, trauma, tuberculosis, intracranial surgery. This results in decreased concentration of aquaporin channels inserted in the principia, leading to inability to absorb adequate amounts of free water, which causes diluted urine, decreased urine osmolarity, hypernatremia, and increased serum osmolality. The hypothalamic osmoreceptors detect this increased serum osmolarity, which causes the patient to report extreme thirst. Patients typically also present with production of large volume of urine, dehydration, and tormented status. Treatment is desmopressin analog of vasopressin. Desmopressin, an analog of vasopressin, which results in recovery of free water via aquaporin insertion in the collecting tubule. Okay, you say normal urine osmolarity is 300. Is it on the thing? Let me see.
It is 300 to 600.
300 to 600. Okay.
If like you have to remember the box of hypernatremia. Serum sodium, if serum sodium is more than 145 milliequivalent per liter, then hypernatremia can come with hypovolemic, euvolemic, and hypervolemic. Okay, if it is hypovolemic hyponatremia, that means uh, total body free water is low and total body sodium is low. Then you have to see the urine sodium. If urine sodium is more than 20, then it may be diuresis or natriuresis. If urine sodium is less than 20, then it may be burn or diarrhea. And if it is euvolemic, like this case, if urine sodium osmolarity is less than 300, then it is diabetes insipidus. If urine osmolarity is more than 600, then it may be due to insensible losses. And if it is hypervolemic hypernatremia, that means total body free water and total body sodium is both increased. It may be iatrogenic, like giving IV fluid and primary hyperaldosteronism. You got my point.
Yes.
I know you hate the chart,
No,
by,
no.
but
Okay.
still I like to say it
Yeah.
because if it remembers, because some there is no clue. I haven't found clue to get diabetes insipidus.
Yeah.
Is there any highlighting point have you found in this question that
Um, um, highlighting.
dehydration, the sunken eye, all goes for these are the signs of dehydration, isn't it?
I just removed everything else. We know it's not UTI because there is no fever, nothing. It's
Okay,
not psychogenic polydipsia because then sodium wouldn't be high. It's not what is that? SIADH because then again sodium wouldn't be high. It's not diabetes because there is no glucose in the urine, and it's not chronic renal failure because creatinine is normal. So that's just how I came up with the diabetes insipidus.
okay.
Yeah, diagnosis.
What is your diagnosis? Just look at the ECG.
Oh
It will
my
tell
God,
your diagnosis.
I hate those. I don't know. I never able to figure it. Okay, wait.
It is very easy.
Uh, I know it's this thing here, but I don't remember how it's called. It's this thing.
Which
It's
thing?
that thing that is going up here or no? Oh, I hate those things we got here.
Like which one? Like look at the RR interval.
What are
It is
okay?
near about 100,
Okay.
and there is you. Can you see the P wave?
No.
So absent P wave, RR interval more than 150, and
Other interval more than
and
150.
it is regular in rhythm. So looks like
It
SVT.
is regular in rhythm.
If you read all the explanation, you don't you will not
Yeah.
gonna find anything. I think it is like SVT,
Okay.
supraventricular tachycardia.
Perfect.
Okay, ready?
Mm, yeah. Oh, can I read the question?
Yes, go ahead. If you find anything, then I will read.
1 month, girl brought to the ED, increasing irritability, difficulty breathing over 6 hours, history of nasal congestion, blah blah blah. Over the past 2 days, she has been given over-the-counter cough, cold preparation every 4 hours without improvement. Suctioning the nose, she has only breastfed once in the past 6 hours. Temperature fine, pulse is high, high, BP low, lungs clear, liver big, spleen, yeah, liver is big. ECG shown. Diagnosis.
If you know
Mm,
specifically in any question, skip the reading because you have the temptation of reading all the questions.
yeah, I do. I do.
Yes.
Okay.
Okay, I'm reading the explanation.
Mhm.
So, supraventricular tachycardia refers to an abnormally rapid heart rate and rhythm originating from above the ventricle, typically with a regular rhythm and a narrow complex on ECG. Patient with SVT can manifest with acute symptoms of lightheadedness, palpitation, diaphoresis, syncope. In patients with signs and symptoms can include pallor, irritability, poor feeding, cyanosis. Infants who present with SVT typically have pulse between 220 to 280 per minute. SVT can be caused by structural defect in his Purkinje system, Wolff Parkinson White syndrome, or it may be provoked by alcohol, nicotine, caffeine. Psychological stress in this patient it may have been provoked by infection or over-the-counter cough or cold preparation, which can contain pseudoephedrine. A sympathomimetic drug can be used as a nasal decongestant. Because of its sympathomimetic effect, it can cause adverse reaction like tachycardia, anxiety, palpitation. Anxiety, palpitation in patients who are hemodynamically unstable. Cardioversion is indicated in the management of the SVT. For patients who are hemodynamically stable, attempts to terminate tachyarrhythmia by vagal maneuver, ice or cold water over the face and with adenosine. Okay,
Okay.
okay, next question. Hmm. A previously healthy 14-year-old girl is brought to the physician by her mother because of 2 month history of left eye wandering. She was born at term, uncomplicated pregnancy, delivery. Eye shows Examination of the eye shows left eye wandering. A photograph of the eyes is shown. The remainder of the physical examination shows no abnormality. Which of the following is the most likely diagnosis? Okay,
Ready?
yes.
So it's retinoblastoma. This child presents with leukorrhea, white papillary reflex, leukocoria, okay, and sensory exotropia, which is suggestive of retinoblastoma. Retinoblastoma is a malignant proliferation of retinal neuroendocrine cells and is the most common ophthalmic malignancy in children. Retinoblastoma results from inactivating mutation of both copies of retinol RB1 gene, which functions as a tumor suppression by halting cell cycle progression at the G1 checkpoint. RB1 mutations may either be acquired or inherited. In cases of germline RB1 mutation, a single mutated allele is inherited, and the second allele acquires a subsequent mutation during development. Infants who carry germline mutations are more likely to have bilateral retinoblastoma with multiple foci of tumors in the eye, whereas infants with two acquired mutations are more likely to have unilateral retinoblastoma. Ultrasound of the eye is helpful for defining the size of the lesion and for detecting characteristic intralesional calcification. Within the eye, large tumor size, tumor seeding, and vitreous of the vitreous humor and involvement of the iris or anterior chamber are associated with a worse prognosis. If undetected, retinoblastoma may invade the optic nerve, leading to a greater risk of metastasis to the brain. Most cases of retinoblastoma may be successfully managed with chemo, although advanced cases may require enucleation with special attention paid to achieving negative margin um, of the optic nerve, negative at the optic nerve, as cases that have undergone metastasis have a poor prognosis. Mhm,
Okay,
mhm. What is exotrophia? This one.
I don't know. You can Google it. I don't know actually.
Exotrophia.
So,
Strabismus, where one or both eyes are turned outward. Okay, just the eye just turned out one. So like this one, I guess. Okay.
like lazy eye.
Not lazy, just turn outward.
Okay,
Just going to the yeah. Because I know there is there in one the one where the eye bulb is coming out is called exo okay.
exophthalmos.
Exophthalm, that's where the eye is coming out. Okay.
Yes, the eye like looks is coming out.
Mm,
Happens
okay.
in Graves' disease.
Exotrophia. Okay. Next.
Okay. A, a 10-year-old boy develops rash on the chest 2 days after returning from a beach vacation. From beach vacation over the next 2 weeks, the lesions spread to the back, abdomen, and the extremities. There are multiple well-demarcated papules, small, thin, round plaques covered with fine white scales over the torso and the extremities. Removal of the scale cause minor bleeding. Removal of the scale cause minor bleeding at this time. There is splitting of the fingernails. Which of the following is most likely diagnosis? Okay, ready?
Mhm.
I got some clue. That's why I am ready.
Good psoriasis. Good psoriasis is characterized by numerous papules and small plaques scattered all
Like
over the surface.
Auspitz sign and Koebner phenomenon. I read in my MBBS a lot, so I know
Um,
this.
Each individual papule and plaque has a small amount of white scale over the top. Like psoriasis vulgaris, removal of the white um, scale causes pinpoint bleeding or spit sign. This is because of the thinning of the epidermis over the dermal capillaries, which are also dilated in psoriasis. Removal of the scales also causes Kopner phenomenon, the development of new lesions at sites of trauma. All forms of psoriasis, including gouted psoriasis, may be accompanied by nail change. The most common nail change is psoriasis is pitting, which is seen in this patient, but onycholycosis, splitting of the nail plate from the nail bed is also common. Presence or absence of nail involvement is a useful physical exam consideration when evaluating any full body rash. Rooted psoriasis is often triggered by a strep infection or by medications. Mm, And though neither of these triggers are relevant in this case, treatment of cutaneous psoriasis include topical therapies such as steroid and vitamin D analogs. If the psoriasis is refractory to topical therapies, then phototherapy, methotrexate, and biologic medications may be considered. Next.
Okay. A previously healthy 13-month boy brought to the emergency department. 1 hour history of 1 hour uh, brought to the emergency department 1 hour after acute onset mild difficulty breathing and persistent non-productive cough. He was born at term. He was born at term following an uncomplicated pregnancy. He was born at term following an uncomplicated pregnancy, labor and delivery. Immunizations are up to date. On arrival, he is alert, but on arrival he is alert but in mild respiratory distress. His temperature is 37 degrees Celsius, pulse 110, respiration 36 per minute. Blood pressure 85 by 50 millimeter of mercury. Pulse oximetry on room air shows oxygen saturation 97%. Examination shows no nasal discharge or stridor. Expiratory wheezes are heard bilaterally. Expiratory wheezes are heard bilaterally, but they are they are greater on the right. His symptoms do not improve. His symptoms do not improve following treatment with nebulized albuterol. A chest X-ray shows a chest X-ray shows hyperinflation of the right lung, but no infiltrate or foreign body. Which of the following is the most appropriate next step in the management?
Ready?
Wait. Okay.
So it's endoscopic examination of the patient's airway. Wheezing that does not improve with nebulized albuterol, hyperinflation of the right lung, and acute onset of difficulty breathing, and cough raises suspicion of foreign body aspiration. Mm. Foreign body aspiration can cause obstruction of the airway, leading to impaired oxygenation and ventilation. Children from 1 to 3 are increased risk for foreign body aspiration because of their inability to stand and mobilize independently, ability to grasp and put small objects in the mouth, and in an immature swallowing mechanism. Foreign bodies can be located anywhere in the airway between the larynx and bronchi. Uh, Children can present with severe respiratory distress cyanosis, stridor, or may have less severe presentation with partial airway obstruction, presenting with cough tachypnea, decreased air entry on auscultation, or wheezing. Chest X-ray can show hyperinflation of one lung, which is caused by air trapping, and partial airway obstruction, in which air is able to pass via inspiration but not exhalation. Foreign bodies are typically in the right lung because of the more vertical um, anatomic position of the right membranous. Management of foreign body aspiration involves flexible or rigid bronchoscopy to remove the object. Object removal is necessary in return for the foreign bodies can be complicated by airway inflammation and infection. It is not seen. Oral administration of steroids will be helpful in a patient with moderate to severe acute asthma exacerbation along with albuterol. Steroids reduce inflammation of airways and have been shown to decrease hospitalization of asthma. This patient wheezing did not improve with albuterol, making asthma less likely. So continuous administration of epinephrine would not be indicated in this patient. Intramuscular epinephrine used in the emergent management of anaphylaxis, which can be characterized by itchiness, urticaria, vomiting, diarrhea, wheezing, stridor or pharyngeal swelling, airway obstruction. However, this patient wheezing is more likely caused by foreign body aspiration, and the patient has no other signs of anaphylaxis. Furthermore, epinephrine is preferred over intramuscular epinephrine is preferred over subcutaneous administration because of its more rapid and reliable thing. Okay.
So in here the clue is like severe sudden severe shortness of breath not improved by nebulized albuterol. That means it is not asthma. And the chest X-ray show hyperinflation of the right lung.
Okay.
And there is wheezes. What are your clues? Like how you figure it out? It is a foreign body.
Oh, I got it wrong, but if I had to do, I would just delete the other ones. We know it's not chest percussion because this is for pneumonia. It's not amoxicillin because he doesn't have no infection. There is no fever. Um, Steroids, you just said that will go with asthma, and they already said that in albuterol didn't work, so it's not asthma. Subcutaneous epinephrine, I guess here you have to be able to know that this is not an anaphylactic reaction. And it makes sense because anaphylactic wouldn't just be one lung. It will be, and the oxygen will be low. So the only
Yes.
thing you have left is the endoscopic exam, which will be for foreign body aspiration. And then you have is a kid between 1 to 3. So yeah, there is a chance of foreign body. The only reason I didn't pick that it was because here it says chest X-ray shows no infiltrate or foreign body. So I thought they were trying to tell me that there is no foreign body. Yeah, but I
Okay.
guess. Uh,
Yes, it makes sense now.
so I guess even if they tell you in the question there is no foreign body, there is a possibility that there is a.
Foreign body questions are very difficult.
Yeah.
Next, a 5-year-old boy has had pain in the groin and thigh for 2 weeks. Has had pain in the groin and thigh for 2 weeks. 1 week ago, he began limping. There is no history of febrile illness. X-ray shows X-ray of the hips shows no findings. X-ray of the hip shows no finding. A bone scan show decreased uptake. A bone scan shows decreased uptake of the right hip. Which of the following is the most likely diagnosis?
Thigh, groin, and thigh. Juvenile, blah blah blah. Mm, Septic arthritis. Sleep capital femoral. Uh, SLA. Toxic synovitis. Mm. Hmm.
You ready?
One moment. Leccarpe verdes. No, not finding. X-ray of the hip. Okay, ready. So it's Leccarpe verdes something disease. Leccarpes verdes refers to idiopathic avascular necrosis of the femoral head that most commonly occurs in young boys, 4 to 9 years. The classic presentation includes low onset of hip pain, which is worse by activity and associated with limb. The pain may or may not be relieved by rest. X-ray often shows no abnormality, however, bone scan characteristically shows decrease. Perfusion of the femoral head, as in this case. Um, MRI may also be considered for diagnosis and will show bone marrow changes. Treatment includes preventing weight bearing on the affected leg. Occasionally may require operative intervention on hip arthroplasty. Inadequate treatment results in fragmentation and subsequent deformity of the femoral head. It is not C, articulojuvenile um, rheumatoid arthritis, also called oligoarticular juvenile idiopathic arthritis, is most commonly in girls aged 2 to 3. Presents with swelling of a single joint, often the knee, with accompanying limping but no pain. On exam, the involved joints are swollen and tender without redness. Unlike other forms of GI, systemic manifestations are characteristically absent. It does not make sense to me. And it's not scurvy. Most commonly occurs in overweight children between 10 to 15, results in displacement of the femoral epiphysis relative to the femoral neck, secondary to anterior superior movement of the metaphysis caused by fracture of the goblet. It is not toxic synovitis, also not transient synovitis, not infectious arthropathy that presents with pain in a joint, often the hip, frequently following a viral infection in a child. It's unlikely in this child who has no infection recently. It has decreased uptake bone scan. Okay, next.
Next,
Mhm.
a 3-month-old girl is brought to the emergency department by her parents because of one day history of fever and poor feeding. She vomited once 6 hours ago, and her parents have noticed several lesions on her skin since then. They say she has been sleepy and had not been acting like herself. She has not had diarrhea. She was born after an uncomplicated pregnancy and delivery. She is at 25th percentile for length, width, and head circumference. Her temperature is 100. Pulse is 180 per minute. Respiration 40 per minute. Blood pressure 63 by 45. Examination shows 3 to 8 millimeter of mercury. Non-blanching erythematous lesion over the skull, trunk, and proximal upper and lower extremity. The remainder of the examination showed no abnormality. Serum studies 136, potassium 3.6, chloride 100, bicarbonate 17, pH 7.32, PO2 38, and PO2 94 and PCO2 38. In addition to administration of the IV antibiotic, which of the following is the most appropriate next step in the management?
Ready?
Ready?
Yeah. Okay.
Can you hear me?
Yeah, I can hear you. Can you hear
Okay.
me?
Yes, yes.
Administration of saline. Meningitis in infants is commonly caused by bacteria. It can present with fever, hypothermia. She has hypothermia? No. or hypothermia, lethargy, irritability, altered status, bulging fontanelle, poor feeding, and seizures. Diagnosis of meningitis typically involves like lumbar puncture, um, an evaluation of the CSF function, increased white blood cell count with neutrophils, increased protein, and decreased glucose. Though evaluation also includes a CBC, blood culture, and urine culture to evaluate for the causes of sepsis, as well as culture of the CSF to determine the bug. This patient has signs of sepsis, systemic inflammatory syndrome that may occur in response to infection. Sepsis can be complicated by shock and multi-organ failure with a high mortality. Septic shock is characterized by vasoplasia, impaired response to of the vasculature to vasoconstrictive stimuli, with markedly decreased systemic vascular resistance, tachycardia, increased cardiac output, oliguria, and lactic acidosis. Okay, the initial step for management of septic shock involve emergency antibiotics and fluid resuscitation with saline. It is not dopamine. Administration of dopamine and or it may be indicated in this patient if the patient continues to be hypotensive after fluid. Fluid should be given first for septic shock. And it's not the administration of sodium bicarb will be unlikely to be beneficial in this patient as the pH is normal, not really. Administration of sodium bicarbonate may be helpful in patients who are acidotic. Okay.
Next,
Yeah. Mm-hmm.
a 4-year-old African American girl has pallor and progressive malaise for 6 weeks after being diagnosed with severe hepatitis C. Examination 4 weeks after diagnosis show improvement in symptoms. She now has scattered petechiae and ecchymosis. Lab studies show hemoglobin 6.5. Lab studies show hemoglobin 6.5, MCB 82, leukocyte count low 2100. Okay, reticulocyte count normal, platelet count low, serum iron maybe normal. A
Mm,
blood smear of normocytic normochromic cell. Which of the following is most likely diagnosed? Anemia.
iron is serum iron is high.
Okay. It is anemia, thrombocytopenia, and leukopenia.
Anemia, thrombocytopenia, leukopenia. Oh, why did I highlight all of this? Uh, okay. Oh my goodness. Okay. Mm, the being diagnosed with hepatitis. Mm,
Ready?
mm, mm. One moment. Autoimmune plastic anemia, acute hemorrhage. Ah, Lord. Between aplastic anemia and autoimmune anemia of autoimmune hemolytic disease. Aplastic anemia.
Are you reading?
Oh no, I'm
Okay.
still trying to find the answer. Okay, I'm between aplastic anemia and autoimmune anemia, hemolytic
Why?
disease.
In autoimmune hemolytic anemia, these two. Aplastic
Yep.
anemia, all the cell lines is low. In here, all the cell lines are low. In autoimmune hemolytic anemia, There may be Coombs test positive. Uh, you have you need some clue for
No,
autoimmune hemolytic anemia to happen.
no.
And autoimmune hemolytic is normocytic normochromic anemia. In there, not all the cell line are low.
Okay. So it's aplastic anemia. Aplastic anemia is most likely cause of this patient normocytic anemia, leukopenia, thrombocytopenia with normal serum iron following infection with Hep A. Aplastic anemia can either be inherited or acquired. Acquired aplastic anemia follow exposure to certain types of viruses like hepatitis, EBV, and HIV. Chemicals, benzene or medications, methimazole, sulfur, antibiotics, and chloramphenicol, or it may be idiopathic. The method of bone marrow progenitor destruction is thought to be autoimmune. Patients who develop aplastic anemia after a viral infection usually present with pancytopenia within 6 months after diagnosis. But symptoms related to pancytopenia, such as fatigue, exercise intolerance, intolerance, spiral, and petechiae, often appear sooner. Diagnosis includes bone marrow biopsy and aspiration, which will show profound hypocellular bone marrow with paucity of progenitor cells of all lineage, with replacement with fat and stroma. Importantly, malignant cells and fibrosis will be absent. Um, Treatment is with immunosuppressive medications or hematopoietic stem cell transplant from a matched sibling if available. It's not C. Anemia of autoimmune hemolytic results from binding of antibodies to red blood cell surface antigen, leading to removal via reticuloendothelial system or to intravascular hemolysis. Diagnosis is made by positive sperm test, unconjugated hyperbilirubinemia, decreased haptoglobin and presence of spherocytes, and reticulocyte on the reticulocyte will be high on the peripheral smear. It's not GHI. Where is it? GH. It's not sickle cell disease, so it's caused by mutation beta globin gene that results in abnormal hemoglobin S polymerizes in hypoxia and causes sickling. Patients have anemia and sickle forms on peripheral smear. It's not trait mutation of in one beta globin gene. It frequently causes symptoms associated with sickle cell disease, such as severe anemia and acute pain crisis. Anemia, if present, is mild. Other cell lines will be fine. Okay, next.
A previously healthy 17-year-old girl is comes to the physician for follow-up after a PPD skin test produced 17 millimeter induction at 48 hours. She takes no medication. She drinks alcohol and smokes cigarette and marijuana. She is sexually active and uses condom inconsistently for contraception. She lives in a rural community and she raises chickens and cows. She participates in student government and volunteers at a skilled nursing facility. She traveled to Ireland for 10 days last summer with her high school. Examination shows no additional abnormality. Which of the following activities is the strongest predisposing factor for this patient's PPD skin test?
So, strongest risk factor for TB. Oh, ready?
Yes.
Uh, in duration exceeding 15 mm millimeters is considered positive result for PPD skin test and is suggestive of latent 2B in this patient. Mycobacterium tuberculosis is a low-growing mycobacterial organism transmitted via respiratory secretion. Presents with primary latent reactivation patterns in primary disease. Patient presents with subacute fever, weight loss, night sweat, cough, malaise. Latent TB can occur as the organism proliferates within macrophage and is maintained within caseating granulomas. PPD skin test stimulates T lymphocyte driven by type 4 hypersensitivity reaction against dermal tuberculin antigen. Causes of false positive PPD testing include prior vaccination with Bacillus calmette-guerin vaccine. These patients' positive test results likely present a true positive. Her most significant risk factor for TB is volunteering in a skilled nurse care facility, as TB is more common and spreads more easily in crowded populations, such as nursing facilities and prisons. Latent TB is treated with prolonged course of isoniazid or rifampicin. It's not while overseas travel to endemic area is a significant risk factors for TB. Ireland and Europe are not endemic areas for TB. Endemic regions for TB include like I guess Africa, India, and Asia. Okay, I guess.
Next,
Nice.
a 7 year a 7-year-old girl is brought for a follow-up examination 2 days after completing 10-day course of antibiotic for her second episodes of pneumococcal pneumonia during the past year. During the past year, during this time, she has had 2 episodes of otitis media, 1 episode of herpes zoster. She was born at term following an uncomplicated pregnancy delivery and was healthy until 1 year ago when she began to have frequent upper and lower respiratory tract infection. Her mother was recently hospitalized for treatment of non-tuberculous mycobacterial non-mycobacterial bacteremia. Examination of the patient shows 2 centimeter non-tender lymph nodes in the axilla. There is fluid behind the both tympanic and the remainder of the examination shows no abnormality. Which of the following is the most likely diagnosis?
Herpes zoster. X-linked acamatobulinemia. Hmm. Hyper IgE. Mm, it doesn't make that much sense. Okay, ready?
Yes.
Mm. Oh, my lord. It's HIV infection. HIV infection acquired via vertical transmission from the patient's mother is the most likely cause of the patient's recurrent pneumococcal pneumonia, otitis media, herpes infection with axillary lymphadenopathy. HIV transmission may occur at any time during gestation, but is most commonly acquired at or around the time of delivery and in the immediate postpartum period during breastfeeding. Transmission is uncommon if the mom is taking antiretroviral and has decreased HIV viral load. As a result of screening for HIV in most developed countries, the incidence of perinatal and pediatric HIV infection has decreased. Although this is not true around the world, while many pediatric patients with perinatally acquired HIV infection will manifest symptoms within the first few months, 2 years, it has been recognized that a subpopulation of patients will not develop symptoms or AIDS defining condition until many years later, as in this case. Symptoms in children are not specific, and AIDS defining condition in children younger than 6 varies slightly from those in older children and adults. Clues to diagnosis in this case include the presence of non-tuberculous mycobacterial infection in the patient mom, which is an AIDS-defining illness, and show prompt evaluation for HIV infection in this patient. It's not hyper IgM syndrome. Is caused by mutation in the JAK signaling cascade, which impairs the development and function of T helper 17 cells. Th17 cells secrete interleukin 17, a potent um, neutrophil chemotaxis agent. So deficient results in poor neutrophil migrations to site of infection. Patients have recurrent skin infections, but non-inflamed abscesses, cold abscess, and diffuse atopic dermatitis. Thymic parathyroid dysplasia or DiGeorge syndrome is caused by 2111 deletion that leads to failure of the third and fourth year. These structures give rise to thymus and parathyroid gland. Their absence leads to thymic aplasia, um, thymic aplasia and hypocalcemia in cardiac and craniofacial defects. Patients are susceptible to viral and fungal infections, so only viral and fungal. Okay.
Okay, can we stop here and do some biostat?
Yes, we may.
So where we are,
Feel like we did confounding. Oh no, wait, let me open this one. Selection. Let me open this one. Maybe that's the one we did. Recall bias, referral. I think we already did that one. Selection and measurement.
yes, we
Restriction,
have done that, I think.
right? Okay. Right, we done that one, right?
Yes,
You think so? Wait, non-response, observer bias, recall bias.
the biases may, okay.
Independent statement, and the kidney
Okay,
biopsy.
selection and measurement bias.
I think that's what we're doing, right? Let me see
Okay, yeah.
the study design. I think we done the study design.
Okay, we haven't started biases. Then, okay,
Yeah, yeah, we did the study design last time, yeah.
okay.
Because I remember the case control and all that. Yeah.
So now selection and measurement bias. Okay, I'm
Mhm,
reading the question.
mhm.
A study is conducted. A study is conducted to assess the relationship between ethnicity and end-stage renal disease. Two groups of pathologists independently study specimen of 1000 kidney biopsy. The first group pathologist is aware of the race of the patient from whom the biopsy came. The second group is blinded as it as to patient's race. The first group reports hypertensive nephropathy more frequently for black patients than the second group. Which of the following type of bias is most likely present? Observer bias, isn't it?
I think so.
Okay. A cohort study. A cohort study is conducted to assess the relationship between a high-fat diet and the colorectal adenocarcinoma. The study shows that no association exists between the exposure and the outcome after controlling for known risk factors: age, fiber consumption, and family history of cancer. Relative risk 1.35, p-value 0.25. It is not statistically significant, isn't it?
Mm, what was the again the statistics? It was 0.5
Zero
point
five,
what? 0.5?
0.05,
0.0. Okay. Yeah, no.
and relative risk includes 1,
How do you know it includes one here?
like 1 minus 1.35. Okay, may now
Mm,
I'm thinking
no. Yeah.
way above. Okay,
Yeah.
The investigator also report that 40% of the subject in high fat group and 36% in the low fat group were lost to follow-up. Based on the information, which of the following biases is most likely to be present?
Next.
Okay. A study is conducted to assess the relationship between the use of the over-the-counter pain relievers during pregnancy and the development of neural tube defect in offspring. Mothers whose children have neural tube defect and age-matched control with unaffected children are interviewed using standard questionnaire. The study shows that the use of pain reliever during pregnancy The use of pain reliever during pregnancy increases the risk of neural tube defect even after adjusting for race and other medication, family history of congenital abnormalities, and serum folate is odds ratio 1.5, p value 0.03. Which of the following bias is the major concern for interpreting the study result?
Next.
Next, a large scale of clinical trial is being planned to evaluate the effect of a non-selective beta blocker propranolol on the clinical course of portal hypertension. The primary outcomes of the study are all-cause mortality, all-cause mortality, and major gastrointestinal hemorrhage, major gastrointestinal hemorrhage. Secondary outcomes for minor gastrointestinal hemorrhage the um, and the number of hospitalization. The investigators are concerned about their possibility that episodes of major gastrointestinal hemorrhage could be over-reported in the placebo group. Which of the following is the most useful technique to reduce the possibility?
Matching and cause mortality. Next.
Yes. In a population with a high incidence of cardiovascular disease, diabetes are at least twice as likely die from myocardial infarction as non-diabetes. A case control study conducted in the community identifies 1,000 people with sustained myocardial infarction and 1,000 people without sustained myocardial infarction. The study are asked whether they have a history of diabetes mellitus. According to the study results, diabetes has a protective against myocardial infarction. Which of the following best explain the observed study results?
Hmm. Latent period. Oh, ready? As a selection.
Okay. Do you want to read or I will read?
You can read.
Sorry.
You can read.
Okay. Sometimes, sometimes study result describing the association between the exposure and the outcome are distorted by the systemic errors in the design and or analysis. These systematic errors are referred to as biases, and in this and distinct from random error, which comes from sampling a population. There are many potential flaws in design that can comprise the study result. The three basic types of bias: selection bias, measurement bias, confounding bias. Selection bias results when subjects are selected for the study are not representative of the study population. Non-responsive referral bias, susceptibility bias, Bergson fallacy, prevalence bias. Measurement or misinformation bias results from inaccurate estimation of exposure and the outcome. Recall bias and observer bias. Confounding results when the effect of the main exposure is when the effects of the main exposure is mixed with the effect of the external factor. Okay, now selection bias. Selection bias results from the selection of the study subjects representative that are not representative of the study population. For example, control subjects selecting control subjects for case control study. Hospitalized patients can potentially bias the results because of the exposure frequency in hospitalized patients does not necessarily reflect the general population. This type of selection bias is called Bergson fallacy. Referral bias results when the patients are sampled from specialized medical center and therefore they do not represent the general population. For example, patient in university hospital may have severe illness and higher mortality rates than individual with the same condition in a community hospital. Other example of selection bias is selective loss to follow-up. This occurs in cohort studies. If people from one group exposed or unexposed who are lost to follow-up are more likely to develop the outcome in questions than those lost to follow-up from the other group. Then selection bias results. A high rate of follow-up loss creates a high potential for selection bias in a prospective study. See question 2. Non-responsive bias may occur when the study design allows the subjects to decide whether or not to participate in the study. Imagine a health survey conducted by a random selection phone numbers. The phone numbers are selected are called and people are interviewed using standardized questionnaire. There are always have would refuse to participate in the survey if the refusal is somehow related to their health status. They are sicker than the general population. The non-responsive selection bias results. Prevalence bias, Neyman bias may occur where incidence of the disease is estimated based on the prevalence and the data becomes skewed by selective survival. Question 5 describes as a case of prevalence bias. Diabetes are more likely die from myocardial infarction than are non-diabetics. If living patients who have sustained myocardial infarction are asked about their diabetes status, it is likely that diabetes will be underrepresented because of non-diabetes and selectively survived their cardiovascular event. Susceptibility bias where Susceptibility bias occurs when the treatment regimen selected for a patient depends on the severity of the patient's condition. Imagine patients with acute coronary syndrome. Healthier patients may be preferentially selected for coronary intervention, while sicker patients may instead be selected for medical therapy. This may create bias where outcomes for coronary intervention appear superior to the medical therapy simply because the subjects who underwent coronary intervention were healthier. Measurement or information bias results from inaccurate estimation of exposure and the outcome. Measurement bias implies that exposure and or outcome data are systematically misclassified. Exposed cases are labeled as unexposed. Misclassification can be differential outcomes in the exposed subjects is misclassified and non-differential outcome in all groups is misclassified. Recall bias is a typical example of measurement bias which should always be considered as potential problem in case control studies. Recall bias can result in overestimation of the effect of exposure. In question 3, the woman whose children have neural tube defect are more likely to report the use of the drug than the woman whose children are healthy. The over-reporting is due to psychological trauma induced by the birth of the baby with a congenital abnormality and search for the potential explanation of the problem. Observer bias, ascertainment and detection bias or assessment bias is a form of measurement bias that occurs when the investigator's decision is adversely affected by knowledge of the exposure status. In question 1, some pathologists' decisions were influenced by the fact of the hypertensive nephropathy is a common cause of end-stage renal disease in black patients. In question 4, healthcare providers knowing that the treatment status or may over or under-report GI bleeding episode, blinding of the healthcare providers is an effective tool to avoid observer bias. Do you want to add something?
Mm-mm.
Okay, okay, okay for today.
Okay. See you tomorrow.
Okay, bye.